Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a couple of cases for you in this video, and this is of patient 1, and we're commencing by treating their right ear, which is fully occluding, as you can see. At the entrance of their ear, they've got these terminal hairs, also known as trachea hairs. So these hairs are designed to protect the ear canal from foreign invaders, so any insects, creepy crawlies, so they protrude outwards, almost like barbed wire. And of course, at the follicle of this hair strand, which is located in the dermis layer, so the skin is 3-ply thick. So in the middle section, the dermis layer are attached sebaceous glands, which secrete an oily lipid secretion, which helps to moisturize the skin and provide the acidic conditions of the ear, which is necessary to prevent pathogenic bacteria from colonizing and infecting the ear. And you've also got ceruminous glands, which are modified sweat glands called apocrine glands, and they produce an emotional sweat. And instead of a watery, salty sweat, it's more of an oily lipid sweat. And again, similarly to sebum, it provides this acid mantle, and they also secrete chains of proteins and peptides, which are chains of amino acids. So they're not amino acids eventually form proteins, but these are shorter chains of amino acids that are not classified as proteins, and they have some antimicrobial benefits. So they inhibit harmful bacterial and fungi growth. And once you're past the hairs, you know that you're on the bony part of the ear canal. So the outer third of the ear canal, the cartilaginous portion, that's where you find these hairs. And beyond that is the bony part of the ear canal. So with the bony part of the ear canal, you don't have the dermis layer of skin, it's only the epidermal layer, the outer layer. So that's one way of deciphering where you are in the ear. So as you can see, we've just got this remaining wax that's lodged in the inferior recess. As we approach the eardrum narrows and it widens again. And when it widens again, it widens at the front section of the ear canal, so the anterior wall, which creates a recess. So we call that the anterior recess. And it also widens at the base of the ear canal near the eardrum inferiorly. So we call that an inferior recess. And quite often, if people poke wax in their ears, it can get it stuck. And you can see just how big that piece of wax is. You wouldn't have thought that it was that size, but that just goes to show how large that recess is, and it's quite deceptive. So I'm just using the fine end. Whenever we approach the eardrum, it's always best to use a fine end because it's got reduced suction power, but don't expose the patient with too much noise with using the full Zollner size suction probe. With the fine end, obviously, there's less surface area, so you're going to get ultimately less suction grip, but it was just about enough to remove that. So patient 1 again, this is their left side. Again, you can see these hairs protruding outwards. So there's a combination of dead skin, keratin and earwax, and this more superficial layer, so that the lateral aspect, it's a lot lighter in colour, and then deeper in the ear it gets darker. So as it's darker, it's oxidized. You have free radicals that are kind of breaking down the wax, and it turns it into a dark, mature colour. It's almost like an apple or an avocado. As soon as you cut into it, it's exposed to air. You've got these oxygen scavengers, and they're in search of electrons. So these free radicals, they are not only byproducts even of respiration. So when you produce oxygen, you have formation of free radicals, which are important to a point, but if they're outweighed by antioxidants, they can then lead to cell death. And so the free radicals, they are highly reactive because their outer shell is missing an electron, so it's in search of an electron, and it can make it highly reactive, and it can try to pinch electrons from talc and obviously other substances, and that's what makes it highly reactive. So earwax, as it matures, you've got this accumulation of free radicals, and it undergoes oxidative stress almost, which gives it this dark colour. So this is patient 2. Patient 2, you can see they've used cotton buds. It's really impacted this wax and skin right up the eardrum. You're going to be really, really gentle, because sometimes the wax can camouflage in colour against the canal wall, so it's very difficult to know what is wax on the canal itself. So just go approach it cautiously. And this is lodged beyond the isthmus, and it's right up against the eardrum. Now, stay tuned for this patient's right ear. So this is their left side, but the right side, they may have very early onset of a canal cholesteatoma, so it's a skin cyst that forms in the ear canal, which is quite rare. They normally form at the top part of the eardrum in the pars flaccida region, where the eardrum can get retracted and then grow inwards medially into the middle ear cavity, and then either posteriorly where the mastoid cavity is, or superiorly towards the skull base. So they can be potentially very dangerous, these skin cysts, because these skin cysts, they're self-growing, and they release a lot of keratinous debris and also proteolytic enzymes, which are digestive enzymes, which literally start chewing up the flesh. And you'll see it on the right side, this patient, it looked quite innocuous at the beginning, just a bit of dead skin just coating the canal, and you would think nothing of it really, but it's only when I removed it, there was an ulceration and a collection of a bit of arteria in there. So it's very, very early stage if it is a canal cholesteatoma. So just refer them to the GP, who should refer to ENT and give some topical antibiotics and anti-inflammatories just to calm that section down. So just using the fine end again. So the eardrum is visible, patient can hear well now. I'm just going to mop it as much as I can, but don't want to, it's wet wax, and a bit of wax is not going to do us any harm. Don't want to overdo it. I know a lot of people like seeing every little last speck of wax being removed, but when we perform earwax removal, it's not like washing your car. It's a different concept. We're just trying to alleviate the patient of the symptoms, and that's why quite often I'm focused on this, to getting sound to go through the eardrum. I'm less concerned about peripheral wax in the canal wall, because that's not really going to affect the patient's hearing. Sometimes you have to peel away some of the wax off the canal wall to remove the wax off the eardrum, but not always. Here it's really, really wet wax, as you can see, and I was able to just clear the eardrum, and you've got this residual bit just hovering over, using the fine end. Obviously, you just want to reduce sound levels. There's a bit at the top. I think I get a bit out, but it wasn't going to come away easy, so we just left it. It's not going to cause the patient any problems. There's a bit of skin there. It might have possibly got a bit of clarinetting, so a bit of the skin sometimes when you suction it, especially with the larger suction probe, it vibrates at the tip, and that emits a very loud, high-frequency squeal. It's loud for the patient and also for myself, so you don't want to put the patient through that. So I think I might just get a little bit more. I'm just going to leave it, I think. The eardrum's nice and healthy. The patient can hear very well. So just going to move on now to there. Well, we will do in a minute. I think I'm going to mop up just at the entrance here, yeah. So the patient had been using some softening drops prior to attending. So the worst thing you can do, guys, is just to poke inside the ears. I know sometimes you may go inside and you're swiveling the cotton bud and you're getting some debris out, and you think, oh, wow, brilliant, you're getting the wax. That's the surface wax. The rest of it, you're probably pushing it and further impacting it in your ears. So again, just remove this keratin off the front part of the ear canal. You'll see why when I do the other side, because there's a similar amount of piece of keratin and there's something hiding beneath that. And you're able to see it straight away. So there's the main occlusion, deeper in the ear. Just to the right of screen at 3 o'clock, you see a bit of soft keratin wax. It looks completely innocuous at the moment. So this came away really, really quite straightforward. So the eardrum's visible straight away. It's going to mop up around the edge, but that keratin has caught my eye, and I'm going to kind of clear that up last. So we're just going to the back part of the ear canal. You can see it's like patient 1, they've got these protruding hairs. So I've just reverted to the fine end. if this is a thinner layer, we probably might have just left that, but because it's thicker, I just want to see what's behind it. And this is, you would think nothing of this, but in a moment we clear this out. And again, I can see the ulceration now. There's a bit of debris that's collected in underneath and a bit of discharge there. It was a bit sore for the patient, so I think we tried cleaning it a little bit more. And then straight to the GP. So the skin is missing, the underlying periosteum slightly inflamed, quite red. Yeah, so that needs to be checked by ENT, just to rule out anything sinister. And just going to mop out the entrance there. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.